The Metagroup system is designed to allow visual implantation of catheters for CAPD, CCPD, and IPD. Accuracy, safety, and efficacy of catheter placement are improved with the system. The procedure is performed on the ward or special procedure room, intensive care unit, or dialysis unit. The patient is awake, NPO for 8 to 10 hours, and has emptied their bladder. The skin is then surgically prepped with povidone iodine. The physician dons hat, mask, gown, and gloves. The deluxe disposable procedure pack is opened. It is completely sterile, CSR wrapped, and is divided into 2 separate trays. The first tray contains all the preparation components. A Mayo stand cover is provided. A full-length transverse fenestrated drape is also included in the upper portion of the tray. Careful placement of the fenestration is made over the desired implant location. Two small incision drapes, also included in the upper tray, are used to narrow down the field of exposure. A small white drape is used to protect the needle scope eyepiece. The cover is removed from the sterilization tray. The light guide is then removed along with the needle scope and placed on the drape. The light guide is then snapped onto the side port of the needle scope, and instruments are laid out on the drape. The needle scope eyepiece drape is opened to cover the eyepiece to prevent contamination of the sterile field. The proximal end of the light guide is handed to the assistant, who inserts the guide into the light source. The assistant turns the light intensity dial to 7 or 8. Secondary packaging material is removed from the top tray, which contains 10 4x4 radiopaque sponges, a 10 milliliter vial of 2% lidocaine without epinephrine, a 10 cc syringe and various size needles, scalpel with a number 11 blade, and a hemostat. In this patient, the choice of catheter entrance site is 1 inch below the umbilicus and the left mid-rectus sheath. The patient had a previous catheter on the right side, which was removed 10 days ago. The skin is anesthetized with 2% lidocaine. Before the skin incision is made, a longer needle is selected and used to anesthetize the deep tissue down to the peritoneal cavity. A 2 centimeter vertical incision is made through the skin to the level of the abdominal wall, not to penetrate the abdominal wall. The skin incision need be just large enough to allow passage of the distal cup of the catheter. Using a hemostat, blunt dissection is carried out to the rectus sheath. The rectus sheath can be felt and identified by inserting a finger into the incision. The bottom tray is placed on the top position and sterile saline solution is poured into the tray for catheter soaking. Tray number 2 has all the elements needed to complete the catheter implant procedure. The filter for the insufflation device is attached to the tubing of the sphygmomanometer bulb that has been steam sterilized. The quill catheter guide assembly is removed from the tray and checked that the trocar is firmly seated in the cannula. The patient is asked to tense his abdominal musculature, and the quill catheter guide assembly is then advanced blindly into the peritoneum at the desired catheter location. This is accomplished using a slight twisting or rotating motion, as with an acute peritoneal dialysis catheter. Entry should be shallow. After the initial insertion, the sharp trocar is removed, leaving the cannula and quill catheter guide in the initial entry position. The needle scope is inserted into the cannula and the luer lock is tightened. The local peritoneal surface may be easily inspected. The presence of highly reflective, vessel-covered surfaces which move during respiration indicates the correct intraperitoneal position of the cannula. The needle scope is then removed and air is placed into the abdomen utilizing the rubber bulb. It is suggested that approximately 1 liter of air be slowly infused for proper pneumoperitoneum for an adult patient. Each compression of the rubber bulb yields 20 cc of air. The sphygmo bulb and tubing must be steam sterilized only. After about 400 to 600 cc of air is in the abdomen, the needle scope is reinserted into the cannula and the tip of the scope directed into the intraperitoneal air bubble. Once the intraperitoneal air bubble is identified, distal vision is obtained. The patient is then lowered into the Trendelenburg position to increase the visualization of the lower peritoneal space and to obtain clear visualization of both the right and left inguinal area. The most open, clear space within the abdomen is then chosen for advancement of the scope. Adhesions are identified and avoided. In this patient, there were 2 adhesions in the midline. The needle scope, cannula, and surrounding quill catheter guide are then advanced into the furthest visible corner of the airspace of the lower abdomen. Adhesions between omentum or bowel and abdominal wall are visualized and avoided. The scope is removed. Intraperitoneal air exits through the catheter guide at this point. The retention ring surrounding the catheter guide and cannula is then removed using a pair of hemostats. The cannula is also removed by a slight twisting motion while slowly withdrawing, leaving the quill catheter guide in the same path previously occupied by the needle scope. The catheter guide is then grasped by hemostats at the lower end of the protruding tab. The tray holds a 3/16 inch and a 1/4 inch diameter plastic dilator. The 3/16 inch dilator is wetted in the saline solution and inserted into the quill catheter guide by slowly moving the dilator in and out gently several times and rotating it at the same time, enlarging the catheter guide. Then, Insert the 1/4 inch dilator in the same manner, gently increasing the quill catheter guide diameter to accept the catheter. The dilators need not run the entire length of the catheter guide, but merely widen the tract through the abdominal wall. This close fit minimizes post-catheter implant leaks. The catheter pouch is opened and the catheter removed. The catheter is then rinsed in sterile saline. The cuffs are submerged and squeezed so that the air trapped in the cuff material is removed. This air removal is important since air inhibits the fibrous ingrowth to the Dacron cuffs. After several squeezes, the catheter should sink into the saline solution. The stainless steel stylet is inserted into the pre-soaked catheter. This will make the catheter rigid enough to insert it within the quill catheter guide. The stylet comes to approximately 1 inch of the catheter distal tip and will not protrude from the catheter when compression of the catheter is made. The catheter is then advanced into the abdomen through the quill catheter guide. The catheter continues to be advanced until firm resistance is met, indicating that the cuff has reached the anterior abdominal wall. This automatically ensures proper cuff location for the distal cuff. The quill catheter guide is then removed while the stainless steel stylet holds the catheter stationary. The slit in the quill catheter guide allows it to widen around the catheter without affecting the catheter or cuff position. The stainless steel stylet is then carefully removed from the catheter, leaving it in the original confirmed visual position. With the 50 cc syringe supplied in the tray, heparinized saline or dialysate is infused into the abdomen at this time. The catheter is tested for patency, and air or fluid may return in the syringe. This may be done several times to eliminate much of the air entrapped in the peritoneal cavity. With a hemostat, the deep cuff is now seated into the rectus sheath. The desired skin exit site is determined by laying the catheter on the skin and marking a site 2 centimeters distal to the exposed subcutaneous cuff. The exit site is then anesthetized with 2% lidocaine. A longer spinal needle is inserted along the desired tunnel path to provide adequate anesthesia. A stab incision at the exit site is made to the full width of the number 11 scalpel blade. This allows a tight seal around the catheter at the exit site. The tunneler is then advanced through the stab incision to the primary incision site with a specially designed tip protruding out of the primary site. The end of the catheter is placed over the tunneler nipple end, which secures the catheter for tunnel entry. It does not have to be tied. The patient does not feel any pain during the tunneling procedure. A pair of hemostats is used to dilate a position and width for the subcutaneous cuff. The tunneler and catheter are pulled through the exit skin site. At the primary incision, a hemostat is used to grasp the lower cuff and prevent dislodging the catheter tip as the tunneler is withdrawn. A sterile connector and patient line is attached to the newly implanted catheter. The line is then connected to a bag of dialysis fluid and is infused into the abdomen. The subcutaneous and primary skin incision is then closed. There is no need for suture material at the exit site. The advantages of this procedure are the fact that cannula location is confirmed before infusion of either air or dialysate. Proper direction of the catheter is possible, avoiding bowel loops, adhesions, and omentum. Quite often, the proper location of the catheter is not in the lower left quadrant, but elsewhere. The peritoneal catheter length is measured, and the catheter may be sized to avoid reaching the rectum or vagina. There is documentation of the number and locations of intraperitoneal adhesions. In this patient, a future catheter would not be placed in the midline because 2 adhesions were documented there. The minimal size of the peritoneal hole allows supportive dialysis to be employed immediately after placement of the catheter. It is suggested to use IPD 3 times a week, or short daily CAPD exchanges for the first week. General anesthesia and heavy sedation are avoided, as is postoperative ileus. There is diminished time and cost of this procedure versus surgical implantation because air is faster to infuse than dialysate. The procedure requires only about 20 minutes to perform. 3 studies have confirmed that 95 to 97% of catheters placed with this procedure show early adequate function.